Hello, everybody. Good morning, good afternoon, good evening. It is a pleasure to have you all joining our session today. To lead our session as a moderator, we have Dr. Yigal Dror. He is a clinician scientist, head of bone marrow failure and myodysplasia program, and past head of hematology section at SickKids. He is an expert in bone marrow failure syndromes, myoplastic syndrome, and hemopoiesis. Thank you very much. And Dr. Dror, you can take it away.
Good morning, everybody, and welcome to this session that focuses on aplastic anemia. My name is Dr. Yigal Dror, and I am clinician scientist at the Hospital for Sick Children in Toronto, Canada. And I will be the moderator of this session. Throughout the session, all attendees will introduce themselves in the chat, can introduce themselves in the chat with name, country, role, etc. As well, during the session, you can post your questions in the chat or Q&A. So we have two excellent talks today. The first talk is on identification and diagnosis of aplastic anemia. This will be given by Dr. Derek Chan. He is a hematology oncology fellow and a clinician investigator program trainee at the Hospital for Sick Children. Dr. Chan works with me and he has a strong interest in studying aplastic anemia and bone marrow failure disorders and develop new therapies. Welcome, Derek, and the screen is yours.
Thanks, Dr. Jor, for that nice introduction. And I want to first start off by thanking the Gansett Committee for the kind invitation to speak at this Congress event. So today I'll be speaking to you a bit about aplastic anemia and essentially what is it. And what we'll go through today is its definition, the medical workup we usually embark on for this blood disorder, treatment options that apply, as well as future directions for this diagnosis. I want to respectfully acknowledge that I'm speaking to you from Ontario, Canada, which are the traditional lands of the Huron-Wendat and the Petun First Nations, the Seneca and the Mississaugas of the Credit River. For this talk, I have no conflicts of interest to declare. So first off, for aplastic anemia, what is it? Well, aplastic anemia is a rare bone marrow failure disorder where too few blood cells are produced. And usually we care about three types of blood cells within our body. Red blood cells are important for oxygen delivery and carbon dioxide clearance. White blood cells are important for fighting off infections, and they also importantly comprise our important immune system. Finally, platelets are important for helping us to stop bleeding. So you might imagine that for a given affected patient, their symptoms would reflect those deficiencies. So they might feel very tired with low energy and fatigue. They might have odd or frequent infections requiring antibiotics, or they may have an increased propensity to bleed or bruise. So unfortunately, we do not yet have a direct marker for aplastic anemia. And so the way that we medically work up this disorder is to exclude other known causes of having low blood counts or bone marrow failure. So starting from the left here, the patient, especially for older adults who might be on several medications, we have to look at their medical listing of their drugs to see whether or not that confers any low blood counts, whether they're on any particular antibiotics. And I think it would be a bit more obvious if they were on any chemotherapy agents. If they were to be diagnosed with some sort of malignancies such as leukemia, lymphoma, or a solid tumor, or if they have been previously exposed to radiation, that could invariably lead to low blood counts. If they had some sort of immune condition, such as lupus or other rheumatologic conditions where they would need to be on immunomodulators, these autoimmune phenomena can also cause low blood counts, and that also must be excluded. Now, a variety of infections can lead to low blood counts due to bone marrow suppression. So, most classically, this could be viruses, but also for more severely sick individuals with bacterial infections in the ICU, that could also lead to low blood counts. Fungi and parasites are also included on consideration. And finally, for nutritional, if it makes sense with the clinical vignette, multiple deficiencies in things such as iron, folic acid, various vitamins, and copper can also lead to low blood counts. In addition to those acquired causes, we also have to investigate other known congenital or genetic inherited causes of bone marrow failure. And the reason for this is to exclude very commonly known causes, such as those that are listed here below. Starting on the left side with Fanconi anemia, this is a bone marrow failure disorder that is characterized by a deficiency in DNA damage repair pathways. Patients who have Fanconi anemia are not only at risk of having low blood counts in the short term and blood cancers potentially over the longer term, but they're also at risk of developing solid tumors because of the deficiencies outside of their blood system, including solid tumors, particularly of the head and neck region. Dyskeratosis congenita is a separate bone marrow failure disorder that's characterized by telomere shortening. Telomeres are the end lengths of each DNA chromosome, and when these are abnormally short in affected patients with TKC, these patients have cells that are not able to replicate or divide. And classically, these patients usually present with a triad of abnormal skin pigmentation, nail dystrophy, as well as oral leukoplakia, or white plaques in the oral cavity. Shwachman-Diamond syndrome is a defect that affects most well understood the ribosome, as well as mitotic alterations. And so the ribosome is an important component of each cell that is important for protein translation. And so when this is altered within cells, that can lead to low blood counts. Classically, for Shwachman-Diamond syndrome, these patients usually present with neutropenia, and they also have growth defects due to a pancreatic exocrine insufficiency. So they have difficulties absorbing what they eat, and they might present with failure to thrive for children, or growth defects in terms of stunted growth as they continue on. Paroxysmal nocturnal hemoglobinuria is our final common bone marrow failure entity. It's also known as PNH for short because of its long name. But what this confers is a loss of clonal diversity due to an immune attack on the blood cells, different components of the blood compartment. And for specific lineages such as the red blood cells, that can lead to an increased propensity for hemolysis or red cell breakdown, leading to abnormal clots in the body, and that could be life-threatening. Finally, we are still in the era of discovering new bone marrow failure syndromes that are defined by a variety of genes, and so there is also consideration of whether or not to send a genetic panel of tests to exclude other rare causes of bone marrow failure for patients being considered for aplastic anemia. So back to the definition of aplastic anemia, what is it? Well, the most common form is acquired or idiopathic in nature once we've excluded all those other explanatory causes. And the pathophysiology behind this disorder is that this is an immune-mediated T cell driven attack on the blood stem and progenitor cells in the bone marrow. And that leads to a variety of cytopenias as well as potential transfusion dependency. The way that we grade the severity of somebody affected by aplastic anemia is per the Comita criteria. Shown here on the right is that criteria where there are severe forms of aplastic anemia, very severe forms, as well as those that do not meet these criteria, which would be considered as non-severe aplastic anemia. So for severe aplastic anemia, you can see that the neutrophils, platelets, and reticulocytes are low. Reticulocytes are the precursors for red cells. Neutrophils are less than 0.5, platelets are less than 20, and reticulocytes are less than 20. When we look at the actual originating source of these cells in the bone marrow itself, the cellularity is defined as being less than 25% for severe aplastic anemia, or can range from 25 to 50% if there's only less than 30% that make up residual blood cells. Very severe aplastic anemia is the same threshold. However, the neutrophils within the periphery are at a lower cutoff. So those that are less than zero point 0.2. And then criteria are none that do not fit these would be considered non-severe aplastic anemia, such as moderate aplastic anemia. I think finally, importantly to note, the conceptual framework for aplastic anemia is that the clinical sequelae that we worry the most for affected patients are a high risk of life-threatening bleeding diatheses as well as infections. So those are the two most important clinical things that we think about for a patient who have low blood counts in terms of their clinical sequelae. Conceptually, at the pathophysiology level, it's important to know that because of that immune mediated attack on these stem and progenitor cells, there's a selective pressure that is quite significant within these patients. And so, at the very beginning, when we see the patient with very low blood counts, they're at this stage of having very low blood counts because of the selective pressure and bottleneck effect. But in the very long term, because of that very impressive selective pressure, that could enrich for maladaptive events within these cells that try to make it out on the other end, and that confers a longer term risk of developing a blood cancer. The treatment options for aplastic anemia are twofold. Because of the autoimmune nature of the a condition, one option is to pursue immunosuppressive therapy or IST for short. The other option is to completely reset the blood system by means of hematopoietic stem cell transplantation. And so for immunosuppressive therapy, the agents that are employed are a cocktail including anti-thymocyte globulin, and that is to specifically target the T cells that are driving this process, cyclosporin, which is another calcineurin inhibitor that also has effects at the T cell level. And then for adult patients, this includes an addition more recently added on to this cocktail, including altrombopag, which is a thrombopoietin receptor agonist, which seems to have effects at the stem cell level to promote the recovery of blood production. The overall response rates for IST ranges depending on the cohort from 60 to 70%, whereas the long-term complete hematologic response, so normalization completely of all blood counts, ranges from around 40 to 60%. The other option that I mentioned is hematopoietic stem cell transplantation, and that involves a completely different set of steps, including donor selection for the transplant, whether that could be a sibling or a parent, or a complete stranger who is a donor. There needs to be careful consideration based on the donor, what is the best conditioning regimen to reset the blood system in order for engraftment to take place. And then finally, there needs to be reagents that are used to prophylax or to prevent complications such as graft versus host disease. The overall survival rate for hematopoietic stem cell transplant ranges from 80 to 90% in general, and then the event-free survival longer term is anywhere from 70 to 80%. So these numbers are a little bit different when you look at both of them and try to compare. However, it's not a simple apple-to-apple comparison because the real-world outcomes can be quite different. Somebody who might be on immunosuppressive therapy might require medications lifelong, and they might have side effects to the medications. Hematopoietic stem cell transplant also has its drawbacks, including very varying degrees of graft versus host disease, graft failure, and needing a secondary transplant. So these numbers do not represent the full picture in terms of the consideration of treatment options to pursue. Now, in 2025 now, this is kind of our algorithm at this point in time. Once we've excluded known causes of bone marrow failure and we arrive at a diagnosis of severe aplastic anemia, we follow this sort of algorithm depending on how old the patient is, whether they're a child or whether they're an older adult. Starting on this left side, if they're a children or adolescent, we look at whether or not they have a matched sibling donor. And so, if there is a matched sibling donor that's available, we go through transplant right away. And that is because historically we know that there are excellent outcomes with a matched sibling donor for resetting the blood system for an affected child or adolescent. However, if they do not have a matched sibling donor that is available, then we usually pursue immunosuppressive therapy as the next line treatment. However, with modern day improvements to haploidentical transplantation, we are now moving into the territory of considering whether or not that might be an option to consider in the future. And current trials, including the Cure AA trial as well as the Transit trial, tries to address this comparison in the future. For older adults with aplastic anemia, similarly, there is a consideration of whether or not they have a matched sibling donor. However, the decision making around whether to pursue immunosuppressive therapy or to undergo transplant is not as clear cut. And that is due to the potential complications and real world outcomes for transplant for somebody who's quite old or frail. And so those considerations are a bit more prominent and important to take into account. And again, these trials that are coming into light to compare IST versus a haploidentical transplant as an upfront option for treatment for aplastic anemia will be important to bring clarity into these areas of question. And finally, for some future directions, beyond the immunosuppressive therapy, there are an increasing number of agents that are being tested now to increase the armamentarium of non-transplant therapies for aplastic anemia. And this includes a clinical trial for ruxolitinib, which is a JAK-STAT inhibitor, emapalumab, which is an anti-interferon gamma antibody, and then rimiplastim as an alternative thrombopoietin receptor agonist compared to L-trombopag. As I mentioned on the transplant side, transplant decision making also is going to be tested with these clinical trials in the CURE-AAA trial for upfront haploidentical transplant for adult patients and transit study for pediatric patients. So hopefully with that, we'll move into some Q&As. Thank you for your time and attention, and hopefully I was able to bring some light into your understanding of this particular blood disorder. Thank you for your time and attention.
Thank you very much, Derek, for the presentation. Actually, the Q&As will be in the end after both talks. So the next speaker will be Kristin Reinhart. And it is about living with aplastic anemia. It is actually a great honor for me to introduce Mrs. Kristin Reinhart, and she will give this talk. Mrs. Reinhart is a board member of the Aplastic Anemia and Myelodysplasia Association of Canada, AMAC. She advocates for awareness, research, and support for patients nationwide. For nearly 20 years, Mrs. Reinhardt has been working as a social worker focusing on several issues related to perinatal mental health. Her talk will be very useful and very important for people and families who have aplastic anemia and for the medical community as well. So welcome, Mrs. Reinhardt, and the screen is yours.
Thank you so much, Dr. Dror, for that introduction. As you mentioned, my name is Kristin Reinhart, and it really is an honor to be here and to have so many of you here today. I don't even know where to start. Dr. Chan, that was amazing. I was just taking it all in. That's so much information that I didn't even know. Having lived with aplastic anemia since 2001, so much information that was very helpful for me to process as well. So thank you for that. I think you can change to the next slide. So as I say that, I won't spend any more time talking about what aplastic anemia is. Dr. Chan explained that far better than I ever could. I can bring the lived experience, but he kind of brought that medical perspective, which was very helpful. The only thing that when I was kind of looking up exactly what aplastic anemia is, because I know what it feels like inside, but I don't exactly sometimes can put that medical terminology together. I found it interesting that where the term aplastic originates from Greek roots, meaning without formation. So essentially an empty bone marrow. So I found that to be quite enlightening. So other than that, I think I'll move ahead, and I think that's been covered very well. I'll get into my story. So for me, it started at age 19. So I was right in the middle of what was supposed to be the most exciting time of my life. I was in my first semester of university. I had moved away from my family home. I was making new friends, exploring my independence. And yet my body was starting to send these subtle signs and unsettling messages. So at first I brushed them off, just thinking I was burnt out, the stress of university. And I kept having these symptoms, extreme fatigue, dizziness, these bruises on my body that would appear apparently out of nowhere. frequent headaches, racing heart, shortness of breath. It just seemed like the symptoms kept accumulating. And I would have these viruses that tend to hang on that I couldn't seem to move through as quick as I once used to. So there were moments that were terrifying. I remember walking across a lecture hall at the university. My vision was starting to blur. My legs started to feel almost too heavy to carry me. It was a kind of exhaustion that I have never felt before, and it was an exhaustion I could not explain to anyone else. And that would be the moment that the fear started to creep in, and I realized that this was more than tiredness. This was my body asking for help in a very serious way. So when I was finally diagnosed, I was both relieved to have some understanding of what was creating the symptoms, but I was also scared. Relieved that I finally knew what was wrong, terrified of what that meant, that my life could be fundamentally changed, that independence, control could be stripped away in what seemed like an instant. So emotionally, it was overwhelming. Mentally, I was confused, being so young. And sometimes I felt like my body was betraying me at what was supposed to be the prime of my life. But what I would come to understand is my body actually was never betraying me. It was trying to guide me towards paying attention, and to understand my limits and my resilience eventually. So suddenly I found myself in and out of hospitals, surrounded by IV pools, blood transfusions, doctors speaking languages that I had to quickly learn to understand, and my world became about blood counts. So, hemoglobin, platelets, white cells, my future was measured in those lab results. I underwent initially immunosuppressive treatment, specifically cyclosporin. I entered into remission, and that long remission actually allowed me to build my life. I graduated from university with degrees in psychology as well as social work. I built a career that I was passionate about and loved. Um, and during those remission years, I was blessed with my two daughters, who are my greatest miracles. Their existence is interwoven into my medical story so deeply, and they are living proof that hope, resilience, science, and timing and grace, um, living proof of that. And every step of the journey, every needle, transfusion, every moment of uncertainty, I've carried them with me. They were and are my motivation and my grounding and my why I fight. So in those years of remission, people saw me as healthy. And in many ways, I was, but aplastic anemia continued to influence my life in many ways. It became a quiet companion, and it still was shaping my choices when I wasn't even verbally talking about it. So then in 2022, everything changed. Suddenly, I was back in the world of weekly blood work, blood transfusions, and uncertainty. My counts began to drop really quickly. I became completely transfusion dependent. I underwent a bone marrow biopsy and revealed progression towards myelodysplasia syndrome, or MDS. So the aplastic anemia was in fact progressing. So that was one of the most terrifying sentences I think I could ever hear as a patient um, with aplastic anemia who had been in remission for so long. Preparing for Then we went on to have the conversation about transplant, and that transplant would be my best chance at survival at this point. So preparing for that transplant was emotionally overwhelming. Um, the idea that someone else's cells, a stranger cells, that it happened to be, as my sister was only a half match, would build would rebuild me was both miraculous, but it was also terrifying. So on May 1st of last year, 2024, I received my stem cell transplant. And that day, it's often called day zero, but for me, it felt like day one, really a new beginning and a literal reseeding of my life. I think you can change slides, please. So living with aplastic anemia. So living with aplastic anemia for me became a daily negotiation with my body. So there's obviously these physical realities, the exhaustion, the bruising, the frequent trips for lab work, the infection risk, frequent transfusions that were both life-saving, but they're also life-limiting in some ways. But then there was the invisible reality. Planning my entire life around my blood counts, navigating the psychological weight of uncertainty, carrying the fear quietly so I wouldn't burden others, feeling isolated in a world that didn't see what you were fighting. Decision fatigue, constant vigilance, feeling like my body was so unpredictable, a sense of being different from everyone around me, and the grief of the things I missed out on. And I also felt this pressure to stay positive when I was terrified. Then out of that came the emotional complexity. So the grief of losing this version of myself, the strength it kept that I needed to keep choosing hope, the guilt of asking for help, the humility of depending on others, but also the gratitude that slowly grows in the cracks of those hardest moments. And yet, even in all of this, there was these wins that I would recognize that just felt so enormous. A stable blood count, or a few hours of energy, a brief walk outside, a moment where I recognize parts of myself again, even a shower on a tough day. So though through both my earlier treatment and my transplant journey, I learned that healing isn't a straight line. Um, it was filled with setbacks, uncertainties, days where I had to find hope in the very smallest of things. I learned that healing is not just physical, it's emotional, learning to face fear and loss, and it's mental, finding ways to stay grounded when everything around me felt so unsettled. Emotionally, as in today, I continue to face a lot. I still face fear. There's relief, there's trauma, there's hope, uncertainty, identity shifts, gratitude, and sometimes I feel all of those at once. So over the years, I've learned that hope isn't naive. It is an act of courage. It's a quiet belief that even when things are breaking down, something new is being created beneath the surface. I'll get you to move the slide, please. So I was doing some thinking about, if I could mentor or, sit with someone that's going through aplastic anemia or starting out this journey, what I would say to them. And so I'm a year and a half post-transplant, and I still carry my scars and my story and my gratitude with me every day. Um, and I've learned that healing doesn't mean returning to who you were. It is embracing who you are now. So it's slowing down, finding joy in the simple moments, appreciating the quiet miracle of being alive. So aplastic anemia and everything that came from that has become one of my greatest teachers. It has taught me that life is fragile and that fragility is sacred. So after walking through a chapter that tested my survival, I learned that ordinary days are actually extraordinary. The quiet moments matter more than the big ones. Resilience is not toughness, it's surrender. My journey taught me that resilience is not about forcing yourself to be okay. It's learning about to trust and trusting your body, trusting your medical team, trusting the timing of your life, the people who show up, and trusting yourself. Also, human generosity and connection has the power to save lives. So I exist today because a stem cell donor said yes. Strangers donated blood again and again. People devote their entire careers to bone marrow failure and research and treatments and advancements. Support shows up in ways that I didn't even know I needed. So our lives are so interconnected with others that in ways that we don't always know. And that's where the meaning lives. And hope doesn't always look like optimism. Sometimes hope is quiet. Sometimes it's stubborn. Sometimes it's simply just taking the next breath, the next step, the next transfusion, the next day. You can move forward to the next slide. So moving forward, so life with living with aplastic anemia is complex. It's gratitude and it's grief, and it's hope and it's fear, it's clarity and it's uncertainty. And it's rebuilding yourself from the inside out, physically, mentally, emotionally, spiritually. So here's what I'm learning moving forward. I talked a little bit about healing not being a linear process. So some days do feel like progress, some days feel like collapse. Both are normal. I'll put that in quotes. Both are parts of the process. And so listening to your body is a form of self-respect. Illness teaches you to live honestly within your energy, your limits, and your boundaries. Listening to your body is an act of wisdom. So, receiving the diagnosis of aplastic anemia, you learn to hear your body in a new way. You learn to honor what it needs instead of resisting it. Um, you learn about identity shifts and the challenges that come with that. So some parts of you, identity challenges you in some parts, but also reveals others. I am not the person that I was before aplastic anemia, and I'm not the person I was before my stem cell transplant, but I'm also not supposed to be. You discover resilience that you didn't know you had and vulnerability you didn't need to acknowledge. So when you survive something life-altering, life-threatening, you begin to see differently. I'm learning to set new and realistic, attainable goals for myself, which has been a challenge because I was very much a go-getter before all of this. I learned to protect my energy, to nurture relationships in a different way, finding joy in the mundane, in the small things, creating meaning out of the struggle. And just before kind of wrapping up, gratitude becomes a way of living. So for me, gratitude, I have so much gratitude for science, for the donor that gave me a second chance, my daughters, for the people who literally and figuratively held me when I couldn't stand up, and for the chance to begin again, even when beginning is hard. So, to anyone out there who is listening, who is walking a similar road, or who is loving somebody who is, please know this, you are not alone. I've learned that healing ripples outward. When one person begins to heal and share their journey, they give other people and others the permission to do the same. So, my hope is that my story can offer encouragement, and that no matter how rare or hard the journey, there's always light ahead. Every transfusion, every treatment, every moment of fear or courage, it all matters. And for the next generation, carry forward not just the medical and the scientific advances, but the humanity of this experience. So lead your journey with compassion, bravery, and the belief that life, even when fragile, is still so beautiful and worth living and fighting for. So thank you for sharing this space with me today and for seeing the humanness in the diagnosis. I appreciate it.
Yeah, thank you very much, Ms. Reinhardt, and also Dr. Chan for these very great presentations. So the floor is now open for questions. I see one question in the Q&A. Oh, I see that the question was actually deleted. Okay, so let me see if there are any. Maybe I will ask a question, and then I will try to find the questions in the chat. Uh, in the chat. So, so this is a question to Mrs. Reinhardt. From your experience, what are the approaches or tools you suggest physicians to use to help patients with aplastic anemia and to cope with their obviously very difficult journey?
That's a really good question. I think, I think for me, it was realizing that I didn't need to know everything to speak up. I had to just lean into remembering that my lived experience matters, and I really understood what it felt like to live in my body day to day. So my confidence, it, meeting with doctors and professionals, grows from not having the answers, but knowing that you're allowed to ask the questions, and that really remembering that your care deserves to be collaborative. And it was a process. It was over time that I started giving myself permission to show up. And when something didn't feel right, to be able to say that and to have that collaborative discussion, and to trust those signals from my body.
Yeah, thank you. So one question: what are the commonalities of severe sickle cell disease and aplastic anemia? So maybe this is a question for you, Derek. What are the commonalities between sickle cell disease and aplastic anemia?
Yeah, thanks for that question. I think just to go back, the previous question, I believe Dr. Drawer was, and I'd tried to answer it in the chat, so I think it underwent the answered tab. Um, but just to answer this question, what are the commonalities of sickle cell disease and aplastic anemia? Well, they're different blood disorders. However, I think that there is an overlap in terms of the patient experience. So both sickle cell disease and aplastic anemia are usually chronic conditions, i.e., patients who are affected may or may not need a series of blood transfusions. And so the actual experience, the lived experience of going through a blood disorder where it's quite an effect on their regular day-to-day can be significant. So the chronicity of their blood disorder is often common. They may be needing transfusions. And eventually, I think that sickle cell disease it may also be eligible for transplant. So the transplant sort of experience can also be similar in terms of the risks and the things that they experientially go through. And so I think that that's kind of where things are common, even though there are completely different blood disorders. The lived experience of having a blood disorder, there's definitely overlap there.
Okay, the second question: a sickle cell patient with recurrent pancytopenia and blood transfusion could be an aplastic anemia. It's also a question for you and Eric.
Yeah, that's a good question. So, it's not that you cannot have two distinctly different blood disorders. Somebody with sickle cell disease could also develop aplastic anemia. So that's definitely a possibility. But I have not yet seen that. Maybe you have, Dr. Drawer, but certainly that could be the case. Now, the sickle cell anemia should usually be an effect that you see in the red cell lineage mainly. And if you start seeing in a CBC or in the blood work that there are other cytopenias, so neutropenia, thrombocytopenia persistently, and there's no good explanation related to a viral infection, for example, some of those acquired causes that I talked about at the beginning, then that is a good reason to consider doing further investigations, such as a bone marrow. And with that, you can determine the cellularity and see whether or not there could be a concomitant or concurrent aplastic anemia that could be on your differential. But that would be a rarity, but it is not impossible.
Um, I'm just looking if there are any more. Oh, there are 1 second, 3 new messages. So I guess this is a comment from Rudy Jaron. In addition to what Dr. Chen said, the conditions vary from person to person. The response to treatment could be different as well. The caregivers need to listen to their patients and provide treatment as needed. Yeah, I agree. These are there are some things that are different. Basically, both of them are genetic diseases. Sickle cell anemia is definitely more common than aplastic anemia, but both of them, as I said, there are the similarities, but also there are a lot of differences. And as Dr. Chen said, in both cases, bone marrow transplantation is an option. It's not that all these patients, obviously, or the majority, actually, there is relatively smaller number of patients with these conditions go to transplant. Um, So another question. This is for Mrs. Reinhardt. Inspired by your ethnicity and grace, if possible, would you share more about your experience about your stem cell transplant?
Yeah, is there something specific I can speak about? I think, in terms of the basic process, um, it was I had to obviously go undergo chemotherapy to break down my immune system. I did ATG, the anti-thymocyte globulin as well in that conditioning routine, and then received the transplant the sixth day that I was in the hospital, and then it really just had to wait for that engraftment process to happen, which happened around day 11, 12. I started seeing my new cells begin to grow, which was a miraculous day to see those numbers slowly start going up every single day. So spent about 30 days in the hospital. And then there was a 3 month, very closely monitored inpatient or outpatient process. So I was up to the hospital 3 days a week to receive, whatever I needed in that time. I never ended up having a blood transfusion post transplant, which is quite incredible. So I've been transplant, I guess, free, if you can say it that way, since before I had my transplant last May. But the process, I would say physically, it was a hard process physically. I lost a lot of who I obviously I lost my hair, I lost weight, I lost my ability to eat. Like there was a lot of physical factors that occurred. However, on the other side of it, it was it was that mental emotional journey that I found the hardest. And I would say the emotional journey is harder than the physical for me personally. Not to dismiss the physical, but yeah, it's just really for me breaking it down day by day. Sometimes it was hour by hour in that hospital, and just I keeping a gratitude journal even in the hardest moments, writing something down, moving my body as much as I could, I was able. Relying on the nursing staff and the people that you do have in your corner, and asking the questions and advocating as best you can for what you need, and if there's something that for me, the nurses and the staff were so incredible when I went through that I could pull them in the middle of the night and they would answer my questions, or they would sit with me if I was having anxiety, and that still continues. I'm still very much monitored by the transplant unit. I will be for a while, and so yeah, I'm not sure if I answered your question or if there was something specific, but thank you for that.
I don't know if you answered all the all what was requested, but
I'll just do a whole new
you
presentation.
yeah, this was a wonderful actually answer.
That was great.
So there is another question which is very difficult. Um, Please, what patients can do if they cannot afford the drugs? This is definitely a very, very difficult question. I will let you try to answer. I have also maybe some additional comments, but yeah, Mrs. Reinhardt and Derek, if you have anything to uh, any response to this very, very difficult question.
That is a
Yeah,
very difficult question. I know for me, I reside in Canada, and so we thankfully we had some private insurance, but I also was eligible for other programs under government insurance. So things like a special support program, exceptional drug status, that really was helpful in bringing some of those costs down. For me, I had a great pharmacy team within my transplant clinic that was a incredible advocate for me. And so I think if there's a way to connect with a pharmacy team, or something in that, or if you have a case manager, a social worker, those people on your team, ask those questions, and see what is available for extra funding, because I mean, not always. I can't speak for everyone, but I know there are, specifically in Canada, where I'm from, there was some extra financial support that I was able to access that significantly helped with the cost of the medication.
Yeah. And thanks, Jane, for your question. I think that it still remains a big problem in terms of being able to translate what options we have in a high income country to a low and middle income country with a resource poor setting. So for patients who cannot afford drugs, for example, IST, we talked about ATG, we talked about cyclosporin, eltrombopag. I think the more pricier options among this cocktail would be the ATG as well as the eltrombopag. So usually those are harder to get in a resource poor setting. I think that in those sort of situations, if the patient receives some form of IST, it may be in the form of just single cyclosporin monotherapy, and that might be a bit feasible, but it's not the full cocktail. It's not the full treatment. So there are definitely limitations, and the chronicity of it still predisposes them to still have infections and bleeding risks. And so that could be like a possibility and when you're really shoved to a corner and don't have options. Transplant is a completely different situation. It might not be practically feasible wherever that patient may be, or it's just not financially tractable for the family to pay for. So unfortunately, there aren't a lot of great options in such a setting, and I recognize that in the on the global scale. So I think that hopefully in the future we'll be able to make improvements not just in terms of treatment options, but also to think about equity around being able to get some of those treatments being accessible to patients who have this rare disorder in other settings who might not be able to afford it. But yeah, thank you for that question.
This is definitely a very difficult questions. I guess one thing is to try to do the minimal and basically to give prednisone as this obviously should be a discussion with the physicians and to see whether there is this is obviously very cheap, relatively cheap drug and by itself is usually is not sufficient, but if there is nothing else, so obviously this will be one thing that needs to be discussed with the physicians and I know from my experience and from discussions or questions that raised from different countries is basically this was the only option. The other thing that may be available in NIH in the States, there is a team that once in a while take some patients from countries that they cannot afford immunosuppressive therapy or other medications. So my suggestion is always to try to get to them and to see if they are still able to get to take once in a while some patients. So this is one thing a second thing that you may do. And in the future, there is definitely a lot of initiative or significant initiatives by people also from our institution and also from the States, etc., trying it from Europe and trying to see how they can help people indeed in certain countries where all these medications are not available. So I hope in the future that there will be more practical or there will be indeed a massive answer to this question, but at the moment, probably it will take some time. So this is really very, very difficult for us also when we get these questions, etc. But try to approach other people and as I said, the maximum that sometimes that you can do is take prednisone. Obviously, it doesn't work it works only in small number of patients, but maybe even smaller response will be good to have. So sorry for the not very, it's an answer that is partial. Okay, another question that we have, how is aplastic anemia usually diagnosed? Is it common to be diagnosed in adulthood? Maybe Derek, you can answer?
Yeah. So I think in my slides that we talked a little bit about the diagnosis. The general conceptual framework again here is that we want to rule out other causes of bone marrow failure or cytopenias because statistically they are more common. Um, Aplastic anemia is a diagnosis of exclusion. And so we have to kind of do that workup before we arrive at that diagnosis. Is it common to be diagnosed in adulthood? It can be. It can be present in adult patients, but whether it's like common in general, I would say no, because it's still a relatively rare blood disorder. But it is relatively in non-discriminant in between children or adults. Both can get affected by this blood disorder.
What I would say, there are also peaks. There is a peak in pediatrics. There are also a peak in very old individuals, and there is also a peak in patients around the age of 40. But yeah, but as Derek said, it is indeed in also pediatrics, but also in adulthood. Any other questions that I missed? There are a lot of thank you notes, and this is great. Okay, I don't see any other questions unless somebody else sees more questions. Derek or Kristin, do you see any other questions? Oh, one new
I do not
message.
see any other
Okay.
questions, no.
Okay, it's more thank you. Okay. Yeah, so thank you very much, Derek and Kristin, for the presentations. These were really wonderful presentations, and thank you for the audience for coming and listening to these questions. And I'm sure that there were many things that from these two talks that you gained. So thank you very much, and we will stop here.
Thank you so much.
Thank you.